Hi, I'm Chandrika Gibson from Breast Cancer Care WA. Today we are co-hosting a webinar with Claire Gray. Claire is a metastatic breast cancer nurse, clinical nurse that is, in Albany, and Claire is co-hosting the Professor Kirsten Auret. I'm going to hand over to Claire and Kirsten now.
Thank you, Chandrika. I would like to begin with an acknowledgement of country. I'm speaking to you from Menang country, Kindarling, Albany, in the Great Southern of Western Australia. I would like to acknowledge the traditional custodians of this land, past, present and emerging, and welcome any Indigenous people watching this webinar. I would like to welcome Professor Kirsten Auret. Kirsten has a Bachelor in Alternative Medicine, is Fellow of the Royal Australasian College of Physicians and Fellow of the Australasian Chapter of Palliative Medicine. Kirsten is Clinical Director of Palliative Care for Western Australian Country Health Service, whose role oversees the governance of statewide public rural palliative care services, caring for more than 1,600 patients at any point in time. She is the Senior Staff Specialist Physician in Palliative Medicine and General Medicine in Albany and Professor of Rural and Remote Medicine at the Royal Clinical School of Western Australia. She has more than 25 years of clinical experience as a consultant physician in palliative medicine, working the last 19 years in rural and remote practice. For the majority of this time, she was the only palliative care specialist outside of Perth. Kirsten leads a rural research programme in palliative and supportive care, with her major recent contributions being in publishing results from rural and remote service delivery and innovation. She's published 71 peer-reviewed manuscripts with over 1,000 citations and has been successful in competitive externally funded research grants as chief investigator. Kirsten is a long-standing volunteer advisor to the Albany Community Hospice and was the Minister of Health appointed expert in rural palliative care to the WA Voluntary Assisted Dying Expert Committee. And finally, Kirsten has an Order of Australia for her work in rural palliative care and tertiary education. Thank you so much for joining us today and giving us your time, Kirsten.
You're very welcome, Claire. Thank you for that lovely introduction. It was a big mouthful, and given that we know each other as long-term colleagues, it was funny to have to listen to you say all of that. I'm very grateful for the opportunity to present, and I also acknowledge the Menang country that I'm on, and I welcome the presence of those of you that are watching later. Claire has asked me to give a short presentation, and then after that she and I will spend some time just talking together about some of the things that have occurred to her in her work about how symptom control might be best managed for people with metastatic breast cancer. So I'll start by trying to share my screen. It's gone very successfully in our trial, so let's make sure it does now as well. This is such a big and important topic for those of us that work alongside people living with metastatic breast cancer. Really because symptom management is a key way of helping people have a better experience in their care, but also in just their ability to live their life the way they want to. As you can see, and you've heard in the introduction, there's lots of different ways that I have contributed to the care of people in the situation we've been discussing. But I wanted to just take some backward steps, just so we can kind of set some foundations for what we'll be talking about. If you'll excuse me for 1 second, across 20 screens, I'm just needing to figure out how to advance quickly, which will only take me a second. Okay, so we've advanced. So part of the background that I wanted to talk about was just spend some time really thinking about when we're talking about symptom management, what do we even mean by symptoms, and why might that be important both to us as caregivers in the setting of metastatic cancer, but also to people and their families. So really, if we place symptom controllers into the very broad goals that people are trying to live out day by day with their illness, which is that most people want to live a life as normal as possible, or even super normal, being able to be present to fulfill their roles and maintain good and loving relationships. So to being able to contribute to their own life in a functional and successful way, but also to be present in the lives of others. And therefore, managing symptoms is thought to be a really important part of how we might maintain an optimal quality of life. And that's such a key word when we're coming to this space, particularly the interface of palliative care, supportive care, and oncology, is that quality of life is this idea that gets brought up quite a lot. And it is actually a really key part of how I practice, but everyone perhaps has a slightly different idea of what that means. So the Australian Cancer Plan's definition of what quality of life is that it's a person's overall appraisal of their situation and their subjective sense of their own well-being. So symptoms are only one part of what gives someone quality of life. So side effects of treatment, the ability to fulfill roles, as we've mentioned, at home, work, school, your social interactions and your relationships, your internal feelings of well-being or distress, your satisfaction with care, your existential concerns, your sexual health and your ability to experience intimacy. All of these build together to give someone a sense of quality of life. And each of these domains have different importance to different people. So for some of the people I care for, what effort they want to put into, for example, symptom control of a particular kind of symptom, may be very low compared to the effort that they want to put in to current management of existential concerns. So for them, feeling grounded, spiritually connected, and having a deep sense of meaning may be a much more important way of increasing their quality of life than, for example, focusing on nausea control. For most of us, though, it's all intertwined and all these things need to happen together. So as you heard at the beginning, I am a palliative care specialist, and for many people, palliative care remains a really frightening phrase to hear attached to you or to have someone suggest to you. So there is a space which is kind of in between, if you like, which is called supportive care. And in practice, most of our work with people is supportive care. So the definition from the Multinational Association of Supportive Care in Cancer is that it's the prevention and management of the adverse effect of cancer and its treatment. This includes management of physical and psychological symptoms and side effects across the continuum of the cancer journey from diagnosis through treatment to post-treatment care. It includes rehab, secondary cancer prevention, survivorship, and end-of-life care. So you'll see when you look at the definition below that many of those ideas of it being holistic, it being active, it being individual focused are there in the definition of what is palliative care. But I guess one of the things that's slightly highlighted here is the idea of suffering, and particularly serious health-related suffering, to people themselves and their families, with more of a focus to those that are experiencing suffering due to more severe illness or those reaching the end of their life. In palliative care, the definition of end of life is the last 12 months of someone's life, but we're often looking after people for shorter periods or much longer periods. So in and of itself, there is nothing about palliative care that is tied to an expectation that a person will die in the very imminent future, but much more of a recognition that a holistic, individualized care plan that focuses on relief of suffering and supports their family is the appropriate kind of care. So staying in this background a little bit longer, what makes something a symptom? I think this is sometimes why symptom and symptom management carry some extra weight in the setting of metastatic cancer, because people will have experienced themselves that symptoms in the past have been a sign that something is wrong, and the ability to act on that symptom has then resulted in presentation to a doctor, perhaps investigations, a new diagnosis, and a new treatment plan. So a vigilance around symptom has kind of got you to where you are now. But at a certain point, that symptom is no longer playing any active role in helping guide your care. So for example, if we stick with pain, perhaps that original presentation of a new pain helped an investigation plan and a diagnosis about some new spot somewhere in your body that you needed to have dealt with, and perhaps your treatment change plan was required. However, continuing to have that pain no longer fulfills any function. And so we really start to step into how can we manage that pain while we continue with other treatment plans to allow you to go on to experience better quality of life and better fulfillment of your roles that are really important to you. And the symptoms themselves could be anything. And it's really then what you come to. Usually something becomes a symptom when you start to call it that in lots of ways. And whatever that symptom is, it's what's important to you and what's impacting on your quality of life. And the range of symptoms we have experienced looking after is really broad, as you can see on this slide. The main ones that most people either worry about or want attention to are actually the first two, pain and fatigue. What we understand in the oncology space is that pain is something we can all align around really easily, and we kind of have quite a good way of working together around pain, where fatigue is something that we struggle more with, partly because we have less tablet strategies for fatigue, but it is often the symptom that people themselves want much more attention placed upon and have much less attention placed upon. But equally, any of these things or any changes within your body that you feel, hey, I think this is different to the normal me, we would call a symptom and we would be interested in hearing about. So how might we approach that? So I'm now going to kind of swap over and say, look, let me explain to you as a doctor that works in this space a lot, how I am being present and how I'm thinking about your problem when you come to me with a symptom in the setting of metastatic breast cancer. So this is kind of my approach. So we'll talk a little bit more about what I mean by holistic as we go along, but it's very much thinking about what does this symptom mean in the broader context of who you are, where are you in your illness, where are you in your life, what other strengths and resources do you have, what other things are you carrying at the moment, what other medications are you on, what goals do you have, what does role fulfillment and meaning look like to you? So really trying to have that broader sense of who you are, and then take a history and examine you in that context. And particularly taking a history and examining someone is a really key part of doing a thorough symptom assessment before we decide what investigations, if any, might be required. And sometimes some investigations are required. Sometimes they can be very, very simple. For example, checking your calcium. Or they might be a little bit more complicated, and particularly in my context, working in rural and remote, a little bit more difficult, like an MRI scan. But all of that can be part of that overall symptom assessment. And this is what I mean about a holistic symptom management approach, because our experience of a symptom has to come from us recognizing it in our brains. So it's that mind-body connection that makes something a symptom. And once we start to be working in that space, we can't deal with the physical in isolation, because our experience of severity and distress around something physical is very much impacted by our psychology, our social strengths and burdens, and our spiritual world. So in palliative care, we talk a lot about the psychosocial spiritual bio model. Outside of palliative care, they talk about the biopsychosocial model, and spiritual kind of gets left off a little bit. And you can see biological meaning to a symptom is given a lot of primacy. So I think one of the things we try and bring in palliative care is much more this sense that we're working with you in a really complex space, and how you perceive a symptom and what might help you manage a symptom and make you better really requires a appreciation of the complexity and interactions between the mind, the body, and that we need to really consider all these domains. So then you might be thinking about how to prepare for being seen by a clinician, or you've got a new symptom and you're thinking, I really want to be able to explain myself well. I really want a good assessment so I can understand, does this mean something's changing inside that's going to have impact for me? How do I bring, I guess, the best information to that consultation so that bit about history and examination can be done really well? So this might be the sorts of things that you might think about yourself. You might even write down in a little diary beforehand, because a symptom diary is very useful for us as clinicians when we come to that assessment piece. So the man you can see on your screen there is Socrates, the Greek philosopher. And we often talk about a Socrates approach to taking a symptom history. So depending on the symptom, it might not always be possible, but we start with sight. So if you imagine pain, where are you feeling the pain or pains? Because in the setting of metastatic cancer, most patients have 3 or more separate pain sites if they have pain as a problem. So sight, then thinking about the onset. Was it sudden? Was it gradual? What's its character? Is it sharp? Is it burning? Is it dull? Is it gnawing? Does it radiate anywhere? Down your arm, into your leg, across your chest? Are there associated symptoms? Since the pain came, I've also noticed that I've had a fever. Since the pain came, I've been going to the loo a lot more, passing urine, and it kind of feels kind of uncomfortable. Since the pain came, I've also found it more difficult to tolerate light, or I felt more nauseous, or I felt a little bit more groggy. Are there particular timings? So if we stick with pain, what makes during the day, are there things that you notice, like, oh, it seems to be there mostly when I wake up, or it wakes me up at night, or it's something that comes later in the day? What are the exacerbating and relieving factors? And this is often something that's so useful for us to understand as clinicians. What makes it better? What makes it worse? What have you already tried? Did Panadol work? Did Nurofen work? Are you taking more of your stronger painkillers? Are they helping? Have you tried a hot pack, ice? What did your physio say? And very much, how severe is it? Severity is something in a symptom that people often find quite difficult and go, well, I don't know how to answer that, because surely my 4 out of 10 is not the same as someone else's 4 out of 10. But I think one of the things that I want to kind of reassure you about is that if you're asked to provide a severity rating, and often it will be something like either a word, like it's mild, moderate, or severe, or you might be encouraged to use a distress thermometer, where you mark where you are on the thermometer, or you might be encouraged to use a number or a color or a smiley face. All of these symptom assessment scales that are used are very much about, where do you think you are now? And it's only as relevant to you. So the next time we come back to you after trying something, we can say, well, what is it now? So the comparisons on the symptom assessment and severity scales are really about, how are you tracking over time, so that we can see for you, has your symptom distress, for example, changed from being moderately severe, perhaps a 5, down to a 2? Or has it gone from a 5 to an 8? And you and your husband, for example, might both stub your toe, and he might say it's a 10 out of 10 and you go it's a 2 out of 10. That doesn't matter. It's really what's your rating within yourself, and what's your rating next time. And these are such useful tools for us to help look after someone. And then where do we go? So as clinicians, and these are the questions I ask myself, these are the questions I teach the doctors and nurses that I work with, is I then step back from this this discussion with you, and perhaps we've examined you, and then I think, really, what could be causing this? Can the symptom be classified? And I'll give you an example of what I mean by this. Is anything else contributing to the experience of your symptom and the broader suffering that you're undergoing? And that's really where that holistic thing comes in. Because if you think about, for example, pain, and you're not sleeping, and you've got some really big worries about your kids or your parents, or you've got a lot going on at work right now, or you're also having to manage some nausea and constipation, all of that together is going to contribute to how severe your pain is, and making small changes in other domains can often really help us fix whatever the primary symptom was. I also ask, can anything else be done to decrease or remove the stimulus? So that's for us, particularly in the cancer setting, thinking about anti-cancer treatments, perhaps radiation treatment, for example. But sometimes it's also something really simple, like, would immobilization help? Would having a walking aid help? Would having a pillow that just doesn't quite crick your neck the same way help? And then what treatment, both drug and non-drug, would be best to treat the symptom? So by the time we get to a prescription, perhaps, there should have been a lot of thinking about this holistic approach to your symptom. So going back to that sort of question about what is causing this symptom, in the setting of metastatic breast cancer, these are the things we need to think about. It may be something to do with the metastatic breast cancer itself. Perhaps there's been a small break in a bone associated with where the cancer is. Perhaps there's been a little bit of a bleed into a metastasis in the liver and a little bit more irritation to the lining of the liver capsule. But very often there's something else, and this is the work we really need to do together, particularly treatment or medication complications and intercurrent illnesses. So, for example, the onset of new chest pain, for example, may be a chest infection. The development of new burning pain in your feet might actually be related to the chemotherapy. And this idea of really trying to understand what is reversible within this symptom, because there are many parts of our symptom management that looks at, could we actually treat any reversible component, and it doesn't require painkillers or anything else. It goes on to, let's say, treating the lower respiratory tract infection. So again, this is coming back to the pain. I talked about, can we classify this symptom? And for many of our symptoms, they've got a kind of structure behind them that helps us understand what part of the body is this coming from. So in pain, we're often trying to decide, is this coming from parts of the body that are really well innervated by lots of nerves? And when you describe your pain to us, it helps us understand that's probably where the problem is coming from, and we would label that somatic. So if you think about, for example, if you pinch yourself on your hand, your skin, your lining of your bones, the lining of your chest, your heart, your abdomen, they're very well innervated by nerves, and our brain can tell us pretty exactly where that pinch is coming from, even if you're not looking at your hand. So we can localize really well, and the treatment plans are therefore different. And if we can't figure out why your body is telling us that a pain is coming from there because we didn't think there was anything wrong there, that will really help us focus your examination and perhaps some tests. But particularly in cancer pain, people also get a different kind of pain that tends to be duller, more broadly felt, and it usually comes from our organs, from our liver, for example, or our lungs. And that can be much more difficult to sometimes explain to someone else exactly where it is. And when you're trying to tell us about it, you might use your whole hand to say, it's just like this whole bit of me is really hurting. But that helps us understand, that might be coming from an organ. And does that make sense in what we understand about where your illness is and what we think's going on the inside? And then the third pain type that we really try and unpack with you, particularly when we ask about what does it feel like, what brings it on, where does it radiate, is neuropathic pain. So for many of you that have undergone surgery or treatment that has peripheral neuropathy as a side effect, you will know completely what we're talking about. So this kind of pain is often burning or electric shock-like. It might be associated with numbness or just the sense that you're not quite sure where your feet are, for example, or like you're wrapped in a bit of cotton wool in that part of your body. And it can radiate along the distribution of a nerve or in very classic patterns. So all this conversation during your history and examination is helping us work out what type of pain is it. And we do the same thing for mood symptoms. We do the same thing for nausea. We do the same thing for many of the other symptoms that we might be brought to try and relieve. And then when we get to the point of going, okay, we're pretty sure we understand what the symptom's due to, and in this particular example, I'm going to continue with pain. You'll remember on my previous slide, I said we then get to the point of saying what treatment. And the best treatment incorporates both non-drug and sometimes drug treatment, because there is a great power from the non-medication management. So particularly mind-body techniques in the setting of cancer pain have been proven to be very, very useful. So things like hypnosis, cognitive behavioral therapy, mindfulness training and mindfulness practice. And in your own life, you'll have noticed already distraction, relaxation training and biofeedback, yoga, and time in nature. These are all proven mind-body techniques that reduce the severity of cancer-related pain. And equally, there are a number of other therapies that might be called physical or complementary, including exercise, physiotherapy, positioning, acupuncture and acupressure. And then again, there's quite a lot of evidence, particularly coming out of the Chinese medical literature, about the very significant role of acupuncture and acupressure for pain. Massage, heat, cold, TENS. So really thinking broadly about how might we manage the symptoms so that we don't just give someone more and more and more tablets. And then when it comes to medication management, there's usually a guideline, a plan, a best practice, something that your clinicians will be reaching for some guidance. And many of our symptoms are managed in a stepwise manner where we start with something simple. And if we're going to use a medication, we'll start with something simple, usually oral, and only one. However, as the symptom progresses, we then start to move up that ladder of complexity. Should we use another medication? Should we use a stronger medication? Should we use 2 medications? Should we use 3? Should we change the route? You were taking it as a tablet, but maybe you need it as an injection for a bit. You were taking it as a liquid, but maybe we should change to a patch that you change every 3 or 7 days. Perhaps we should get some medications compounded so that you don't have so many tablets. Perhaps we can give it to you as a cream. Perhaps you might have it up your nose. So I think really, I think the reassuring thing is that there's always a plan B and a plan C and a plan D. And for most of us, the plan A will work. So a relatively simple plan works about 90% of the time, but there's always the ability to have a plan B, which generally will come with a bit more thought or a bit more complexity, but there's a lot of guidelines around how we might do that together. So I'm going to stop sharing now because we had agreed that we would have some Q&A time, and Claire's got some good questions. So hopefully this will stop sharing. And I can see that Claire and I are back together again now.
Thank you, Kirsten. That was a wonderful description about how palliative care and symptom management in the space of metastatic breast can really help people holistically. And I love the description of Socrates. That is it's really good to keep in my mind as well when I'm talking to people about trying to draw out what the how people describe and can help me understand how they're feeling. So thank you.
Oh, you're welcome.
I do have a few questions. Is there a cost involved in having palliative care involved in somebody's treatment as an inpatient not as an inpatient, sorry, working alongside oncology and seeing people in the community?
Yeah. So one of the things that's probably worth explaining is in the Australian context, we think about palliative care as kind of being an approach to care, if you like, that could come from many of the people that are already being involved in your care. So, for example, your GP may be providing you palliative care because they're focusing on your symptoms, they're caring for you holistically, they're supporting you and your family. And we would call that palliative care. We would also, in the Australian context, call that generalist palliative care. So your other specialties that are involved in your care are providing you generalist palliative care or parts of the palliative care skill set. So that would be your oncologist who's trying to help manage your nausea and giving you some painkillers. It might be your breast care nurse. It might be others that are involved in your care. So we call generalist palliative care that comes from either your GP or other specialties involved in your care. And a lot of the palliative care work day to day is done in that space. And then there is specialist palliative care, and that involves clinicians, doctors, nurses, social workers, and others who have got extra qualifications and training in palliative care. And in the medical field, that would be the equivalent qualification as a physician as your oncologist. So we have the same length of training program, we have the same rigor around curriculum and training, and the same requirement to pass benchmarks and qualification milestones. So specialist practice has a particular level of depth, and we particularly feel we want to be present and supporting patients that have more complexity in their care, which means that sometimes we come and go in the care of a patient with metastatic breast cancer. Like someone might meet us a couple of times, there were some more difficult problems to nut out, and then we step back a bit, and then something else might come up, perhaps a symptom that's more difficult to manage, or a situation where it really needs to be a team around you helping figure a way forward, and we would come backwards and forwards. So specialist palliative care can be a one-off referral, a very much walking the path together. So you see oncology and you see palliative care in outpatients regularly, or it might be quite an intense interaction where perhaps you might be in hospital and a symptom's very difficult to manage, or you might really be in your last days or weeks and you need that kind of care. So then how you access specialist palliative care and what it costs, that's where I'm kind of getting us there. So where you are in that kind of space might make a difference. So perhaps you are seeing specialist palliative care in a public outpatients, perhaps you're seeing it in a private hospital outpatient, perhaps you're seeing your specialist palliative care practitioner at home in the community from a service, or perhaps they've been asked to become part of your care team while you're an inpatient, either in a public hospital or in a private hospital. So once we divide public and private, that's where the cost is going to be. So in general, there would be no costs put back on you if you are in a public setting. If you are in the community, however, you generally will be paying for your own medications through having a script and going to the chemist. When you're in a private hospital or in a private outpatients, each specialist is negotiating with you with a financial consent contract what they charge. So for some palliative care physicians, there may be a cost to you, an out-of-pocket cost, or there may not be. And that would just be something you'd have to really talk through and make sure that you've given financial consent. For the majority of our patients, once you're at home, lots of the medication costs around symptom control are covered by you. So your chemotherapy is provided by the hospital. You don't know how much it costs. You don't have to go to your local chemist to go and pick it up. But for example, if you're on a slow release painkiller, that script is often something that you are getting renewed through your general practitioner, you're going to your local chemist, and you're paying whatever a normal script cost is. Some of the medications we sometimes use in palliative care are not on the PBS, so they will cost more for patients, and again, that really needs to be a kind of open disclosure process, because the cost of care can be cumulative and large, and palliative care absolutely tries to be aware of that, because we're aware that financial toxicity and financial stress adds to the burden of what you're having to bear and makes it more difficult for you to manage your own symptoms and your own well-being and your own quality of life. So we try not to just add to that, but feel free to ask.
Thank you. So I think through your talk, you have described the difference in palliative care and oncology, but can you talk some more about how that service looks?
Yeah, sure. Okay.
An outpatient?
Yeah. I think I've been very lucky because I actually rurally helped run an oncology service for many years. So I feel perhaps I've got a particular sympathy to some of the challenges of what an oncology service has to deliver, and obviously deeply understand what a palliative care service is trying to do. So again, I think what is the same? We are both here to provide person-centered care. That's a core value in both services. And we both are ideally multidisciplinary services. And your care is planned in multidiscipline forums and case discussions. So I think we have some really shared values. And therefore, the way we're structured and the way we work is quite similar. But if you reflect on your oncology service, you probably see a specialist oncologist. You may see a specialist breast cancer nurse, or perhaps even a specialist metastatic breast cancer nurse. There may well be a chemotherapy pharmacist involved in your care, and there may be a social worker or a counsellor or other people involved in your oncology service. In palliative care, those types of disciplines are exactly the same. I think what we would say is that we probably have a slightly bigger space for general practice in many palliative care services around the country also employ GPs as well as the registrars and junior doctors you're used to seeing. So the kinds of people you'll see in both services are the same. Nurses play a very important part in the day-to-day delivery of palliative care. Perhaps that might be a little bit more than what you might be used to in your oncology service. You might be surprised that the appointment times in palliative care are generally a bit longer. So, you might be used to your appointments perhaps being a little bit quicker. We try and make them a little bit longer to be able to do those proper assessments. What else would I say is different? I think we need to spend less time really focusing on your anti-cancer treatment in and of itself and getting to the nitty-gritty of that, although we do need to understand that and have capacity around it. The other thing, though, that's quite different is most of us are generalists in specialist palliative care. So in any one working day, we may be looking after you with metastatic breast cancer, and later we'll be looking after someone with motor neurone disease, and then we'll go and see someone with kidney failure on dialysis, and then we might, particularly in the rural context, quickly go and see a child. So we have to come as partners with your oncology team to understanding the nuances of your care. And so we might not be expert in this latest drug or what clinical trials available. Perhaps where our expertise really sits in that shared domain of humanity. Like, although many illnesses have specific ways that they are presented or treated, many aspects of serious illness are the same, and many aspects of how we cope as individuals and how we find meaning and what we go through and how symptoms might be managed is actually the same within, the individual variations, and that's where we're experts. So we carry an expertise in the human experience of severe illness, and we carry expertise in the specific management of symptoms with a real depth that might not be matched by disease depth. So that will be the difference that you will notice. And you will see that if you ask your palliative care specialist about are there any clinical trials available for your particular condition, they will just need to refer you back into your oncology discipline. Equally, if you ask your oncologist, is this the best antidepressant for my low mood right now? They might go, you've got a lot of symptoms going on right now and there's a lot of stuff. What about you take that to your palliative care team? They're probably better at trying to work that out with you. So we do this kind of bit of backwards and forwards depending on our skill set.
Lovely, thank you. When would you suggest that is the best time for somebody to be linked in with a palliative care service?
That is the multi-million-dollar question. Lots of research going to that. But really, what do the guidelines say in Australia and internationally? The broad answer is early. Early referral is better. So what is better? So we know that when we have done trials in the setting of metastatic cancer, the things that are better is symptom control. So the focus on your quality of life rather than having so much of our specialist brain focused on your treatment improves your quality of life and improves your symptom control. The opportunities for advanced care planning are better. So that really is sitting with someone that says, what are your goals and values and priorities? How does the future look like you? Do you have any particular worries? What things are you striving for? Are there things you'd really like or situations you'd really like to avoid? Advanced care planning is more likely to be present so that you and your family have had some preparation time should something change or go wrong. And there's really good evidence to say some preparatory thinking about what if scenarios reduces the stress and distress in both patients and families when they're at the pointy end. And it's impossible to think about every complication or scenario that might arise for every individual patient, but actually that isn't what's required to make a difference. It's just having some support to do some what if thinking, and then it can be packaged up again and it's been done. And that practice really reduces stress, distress, anxiety, and depression in patients and families after something's happened. So better symptom control, better advanced care planning. Interestingly, a little bit less healthcare utilisation, so a little bit less ED presentations and a little bit less unplanned admissions to hospital. At the end of life, more likely to be cared for and die in the place of your choosing. And interestingly, this study hasn't been done in the metastatic breast cancer setting, but it has been done and repeated in the metastatic lung cancer setting, longer life. So patients that are referred earlier to palliative care services alongside their specialist oncology services are living longer. So it has become best practice for those patients. So why might you live longer to have good palliative care alongside good oncology treatment? It's probably related partly to your good symptom control because that will allow you to be more functional, eating, up and moving, engaging with family. That actually keeps you alive. The other thing might be that having another team that can sit with you when you're making decisions about sometimes very complex, potentially very toxic, potentially life-threatening treatments if they go wrong, means that sometimes people as a population elect not to have those treatments and actually therefore live longer because they experience their full natural life rather than experiencing a much more experimental, highly toxic treatment, which shortens their life if it goes wrong. So we haven't really completely been able to unpack why do people with good palliative care alongside specialist oncology do better if they have metastatic lung cancer. Why do they live longer? But those are the two main reasons people are talking about, and I feel are probably true.
Thank you. So what makes somebody eligible to be referred to a palliative care service?
So each palliative care service will have slightly different referral criteria, and your oncology service will be working with them and will understand what they are. Most palliative care services have a very open door because we are very happy to be involved in the situation. And if you're doing great and we're not really doing anything for you anymore and you're not seen to have any palliative care needs, we'll just step back for a bit. So most patients that are seen and accepted by palliative care services need to have a life-limiting diagnosis. So metastatic breast cancer would be considered a life-limiting diagnosis. The other part of it is this broad term, two broad terms, either, as you saw in that definition at the start, serious health-related suffering. Or the other phrase that tends to be used is has palliative care needs. So that might be you have symptoms that we would like to focus on. You'd like some support with advanced care planning. You'd like some support with prognostic discussions. You'd like some support in the psychosocial and spiritual space. So really having a diagnosis of a life-limiting illness and then having palliative care needs of some sort is generally when you'd be picked up by a specialist palliative care service. In my service, we generally are referred patients across all diagnoses in their last 2 to 3 months of life. We would consider that a bit late. So those patients have been living with life-limiting diagnoses for many more months and years. And if you talk to them about what's been going on, they've often had quite a symptom burden for a much longer period of time. And to try and ask someone who's now very close to the end of their life to engage with a new team, to meet new people, and to perhaps make some very big decisions about what kind of care looks like good care, what do they want, what do they don't want, with a new team in your last couple of months of life, that's quite a big psychological burden. It takes a lot of ourselves to really have those conversations. So most palliative care services are trying to move away from any prognostic thing. If you look in the American literature, they will often say specialist palliative care services will only accept you if you're in your last 6 months of life, and that's to do with their managed care model. So hospice services, which are paid for by insurance companies in America, have this prognostic thing of 6 months, but that is not the case in Australia. So it's very much more about your diagnosis and the fact you've got palliative care needs, about the referral, and then how often you're seen and what gets done and which team member sees you. That's what gets worked out together.
I like the idea when you were saying before about almost dipping in and out of somebody's care, that you don't have to be present all the time, because it can get quite onerous if somebody's coming into hospital, having appointments, scans, tests, and then seeing more and more teams. So going in, doing what you need to do and stepping away and engaging as much or as little as needed is, I think that'll be quite welcome to a lot of ears today.
Yeah, because I think one of the things that helps us look after you is a little bit of getting to know one another. So we call that the therapeutic relationship, that we know a little bit about what's important to you, how you like information, what your strengths are, what else is going on for you, but you also know us a little bit, and that you've got a bit of a basis of trust. So establishing that at some point, it tends not to go away. So I find that once we have established some sort of therapeutic relationship, we can pop back into it really quickly. So I think that's that value of that kind of early meeting. So you might go away from this presentation and say, you know what, I might say to my oncologist, I'd like to meet the palliative care team he works with. Because you can drive the bus. You can say, I want to meet you. I want to see if you're my kind of people. Explain how you work. Do you charge anything? How would I know when I need you more? Are there triggers and red flags that I should watch out for? Have you got any suggestions for how I'm managing all these things now? What about I catch up with you again in 3 months? Or can I just call you if I need you? Or what about I just keep working with my GP and my GP or my oncologist lets you know when I need you again? All that's fine.
But I know you have talked about this. So one of the questions that a lady asked me was, does it mean that I'm dying if palliative care are involved? And also another question that she asked was, can I die at home if I choose?
Yeah, all right. Those are really big questions, and I'm so pleased someone asked you to ask them. Probably the most common experience I have when I sit with patients and families after they've been referred to specialist palliative care for the first time was how that landed with them as very frightening, because the subtext was, you're going to die soon. So I think you'll have seen from the fact that I've said in my service, patients are referred to me in their last 2 to 3 months of life. The way the system works for most people is they're being referred late. So if you talk amongst your friends, for many people, palliative care became an important part of their journey when they were dying, when they were in their last few months of life. So that connection is very strong in our system and in probably the experience of those people around you or your family members. But I think we need to really clearly move away from that and say, no, the reason a specialist palliative care referral is made is that you have a life limiting, and in many services now that's a life threatening. So particularly in pediatrics, that's been changed to a life threatening because kids can get really sick and then they get better and they're well for the rest of their lives. In the transplant setting, we do the same thing. We can be intensely involved in someone pre-liver transplant. Once their liver's transplanted, they're well and off, and we're gone. So there is much more this sense of that's what it should be. So I really resonate with what your lady said, which is I'm worried that it means I'm dying. And I think we just would have to talk about that. So be open to say to the person who makes the suggestion, why are you referring me? Are you kind of like trying to give me some other mixed message here? Does this mean something's changed in my prognosis? And you can work on that together. But equally, it'll be something your palliative care service is really comfortable to help you unpack. If you can be brave enough just to take that step, we'll help hold you through all of that. I think one of the differences with that definition of survivorship, where it talked a lot about supportive care, it talked about survivorship and it talked about rehab, and our expertise in palliative care really is about walking with where you are now and coming in if you are deteriorating or really suffering at any particular point and when you're dying. And that dying bit can be a really difficult part, but I also want to say very clearly, we're good at that. And having a therapeutic relationship with someone that can help you when and if that time comes is so important for your experience, your quality of life during that period of your life, but also for the well-being of your family and your friends. So again, we know that people that are cared for with enough time to make a difference, their family and friends are generally much better afterwards because they've had that kind of support during the process. So there is a kind of sense of wanting to just very quickly say, oh, it's nothing about dying, palliative care. It's all about your symptoms, it's all about your quality of life. But that's not fair either, because I think it also then minimises the fact that we actually also have an expertise in caring for people who are dying that is unique and deep and compassionate and skillful. And all of us will need that care at a certain point in our lives, or our mums will, or our dads will, or someone will. So I also don't want to minimize the fact that we have this expertise that is absolutely tied to dying, because that is actually important as well. That is an important skill, even if we don't want to think about that. And then your question, just to finish off, can I die at home? It does vary across Australia. It's a really important question because if you ask people out in the street, where would you like to be when you're dying? More than 75% of us say, I want to die at home. And for many, many, many of us, that is a choice. Care can be done at home and you can die at home and you can die very well, peacefully, your family very well supported. But not in all locations will care be available 24/7. Not in all locations will be there someone who can visit you at home. So it's a conversation we kind of need to start earlier. Practically, what may happen for some people is that they have as much care as possible at home. And then sometimes people say to me, you know what, for the last bit, that can be wherever it needs to be so that my symptoms can be managed and my family cannot feel burdened. So practically, only about 20 to 30% of people actually do die at home, despite many, many, many more of us wanting that. But for specialist palliative care services, we're completely aligned with you having care and the choice to die where and how you want, and we'll work with you around that. And home is absolutely a core priority for us, if it is for you.
Thank you. Final question. How does the assessment and management of symptoms differ in palliative care setting from the oncology setting?
I think we probably put a little bit more energy into the assessment phase of symptoms before we move to a script pad. We very much are trained in that psychosocial spiritual bio model. We have perhaps a broader expertise about what's available in the community and the non-drug treatment for symptoms. We're perhaps a little bit more experienced through working with many others having that symptom from different disease categories. So we may have an idea that they don't have. We tend to be better at the plan B, the plan C, the plan D, where the oncologist is really, or the oncology service is often really good at the plan A. We're also perhaps a little bit better at managing multiple medications. So thinking about your tablet burden and try to find our way through that. So I think those would be some of the key differences in the approach.
Thank you. That's my question is done. Thank you very much.
You're very welcome.
I would love to offer the deepest gratitude to both of you. That was meaningful and reassuring, I think, for people listening. And as I thank Claire and Kirsten for your experience, your expertise, and your time and energy today, I also want to remind people watching this webinar that Breast Cancer Care WA has 3 metastatic breast care nurses in our team. We have a team of counsellors. We have the Living Well programs that include some workshops that include things like leaving a legacy and around this kind of space. We also have yoga therapy, we have exercise medicine, we have mindfulness training and practice. So some of those complementary and integrative areas that Kirsten mentioned that can really help with symptom management along the way. So again, I'm very grateful for having you both here with us today. Thank you so much, and we'll see you again soon.
Thank you.
See you later. Bye.
Bye.